thank you very much for joining us today, and welcome to Live Longer Better in Hertfordshire's third online event. This is our second masterclass webinar. My name's Will Slemmings. I lead the health team at the Heart Sports Partnership, and I lead on the Live Longer Better in Hertfordshire movement, where ultimately we aim to use physical activity to encourage longer, healthier and happier lives for older adults in Hertfordshire. We're delighted today to have Verity Forbes from the Hearts Care Providers Association. She's going to lead the webinar throughout the next hour. I know we've got loads to get through, so we're not going to kind of cover too much about Live Longer Better in general. But if you are new to the movement, I know there's lots of people that have signed up for the first time for this event. You can go to the website, and recordings of the first few webinars and events and loads more information are on there that you can catch up with. So before I pass over to Verity, just some very quick webinar housekeeping. So to let you all know, this is using the webinar function on Zoom, so you will remain muted and with your cameras off throughout the webinar, but we do encourage as much networking and communicating through the chat function as possible. So please do get on there and let everyone know who you are and why you're here, and any other messages you want to get on there. I would press, please do, if you do write on the chat, please select all attendees and panelists, because otherwise it only comes to me and Verity, and we want you to be able to talk to each other throughout the event. If you do have a specific question for either myself or Verity, then please use the Q&A function at the bottom. We'll keep an eye on that throughout, and we might pause for questions throughout the event, but if not, we'll try and save time at the end to address all of the questions. The event shouldn't last any longer than an hour, but like I said, I do know we've got a lot to get through. So if we do go over that hour mark, please feel free to stay with us. But obviously, if you need to get off, I know lots of people have got lots of things on, then please we'll circulate the recording next week, so you'll be able to catch up with everything that you missed at the end. But please do feel free to stay with us as long as we're going. And as I mentioned, the webinar will be recorded and distributed early next week to everyone in attendance and everyone in the network. So without any further ado, I'm going to stop sharing my screen, and I'm going to pass over to Verity, who is going to talk to us about falls prevention.
Perfect, thank you, Will, and welcome everyone. I've been seeing you all pop up. I know quite a few of you, so it's lovely to have you on this morning. Just a quick introduction about my background. So I work for Hearts Care Providers Association. Our main project has been Stop Falls, so you may have heard about us. However, we are moving towards a new project name called Prevention and Enablement, because we know that generally we're not going to be able to stop falls completely, but it's more about quality of life, making sure we're getting people moving, getting people up on their feet, and staying well, even more so since the last 18 months, 2 years. So primarily I work with care providers, I work with care homes and home care providers in looking at their falls and looking at education. But we also have a lot of resources available to everyone in the community too. So hopefully you'll be able to gain some new information from this morning. So we're going to get cracking. I'm going to share my screen. My email address will come up, but in the recording you can also view it. So please feel free to jot it down and ask me reach out to me after, which is absolutely fine. So I'm going to share my screen. Okay, everyone. So there we go. There's my email address at the bottom, and also our Stop Falls website, which hopefully many of you have already been on before. All you have to do is just search HCPA Stop Falls into Google, and it will come up. But why is this so important? The importance of training and falls awareness and prevention. We know how prevalent falls are within the community, within old adult care services. We have to be proactive in preventing falls. Being proactive is something that has been recently evidenced towards prevention. We have to look at what we can do to keep people as well as possible, and promote independence in a safe way. So as I said before, we're never going to stop falls completely, and it's never our remit However, it is to make sure we are still promoting an enabling culture to promote quality of life. So again, we show it's important that falls prevention is taken seriously to increase quality of life and to keep people well and prevent harm and injury to those that you look after, and also to prevent potential safeguardings as well. So what we're looking at is some key statistics with falls. Some of this might be new information, some of it you may know already, is that each year cost of falls is £2.3 billion. Out of those £2.3 billion, hip fractures, which we know is a huge injury from falls, cost £1.1 billion. And that is an absolutely huge amount of money. If we think how much that is just on one injury, and actually how big that injury is for people. We know that some people don't ever really recover from a fall or some major surgery or a major injury such as hip fractures. Unaddressed falls hazards within a home costing £435 million. We know that external risk factors and things in our environment, which I will go through, is a big part of falls within the community. 50% of over 80 years old individuals who are over 80 years old fall. Hospital bed days due to hip fractures, 1.8 million hospital bed days a year. Generally, just to call for an ambulance, and we know the stress that there is on getting an ambulance out in good time, generally that can cost around £230 to £235 just to get an ambulance out. A&E cost before treatment round about £100, and there is 30% of those who are over 65 years old fall every year as well. So some key statistics with falls taken from gov.uk, taken from NICE as well, the National Institute of Care and Excellence, where we get a lot of our information from. But I wanted to share with you a little bit about prevention as well before we get going, specifically on falls. The Social Care Institute for Excellence, also known as SCI, released some prevention guidance a few months ago. And I think it's really, really important because it just sums up what we're all trying to do in our different fields. And I've seen that some of you have been writing where you work, and I think we all are trying to have the same approach, which is really important. So we must encourage people to be more proactive about their health and well-being. We know that it is so much more than just a fall that happens. We must increase independence and reduce and potentially delay the need for care and support services. So the prevention guidance, there's a lot more than what you can see on your screen. We have got prevent, reduce and delay. And prevent is this first approach that we are looking at a range of facilities that are around services, resources that can help avoid the need for care and support developing. So it could be information and advice promoting healthy and active lifestyles, and reducing loneliness and isolation, and making sure that everybody has a huge amount of knowledge, and we're always building on our knowledge to help keep people well. We've then got reduce, such as early intervention. So we're looking at those specific individuals potentially at a higher falls risk in developing needs where support may slow this process down or prevent other needs from developing. And that is so important. We don't just look at doing something when it's already happened. We're looking at what things do we need in place to support those who are looking after. And delay, formal intervention. So the third approach is aimed at people with established complex health conditions to minimise the effects and support them to regain skills and to reduce their needs wherever possible. This could include rehab, enabling services, meeting somebody's needs at home, providing respite care, peer support, emotional support, and also stress management for care staff too. So please have a look at this guidance, prevention guidance from Sky. Again, it's really easy to find on their website. Please have a look, and hopefully, you know, we are all wanting to take this approach to keep people well. The next thing I'm going to show you is something that we developed because we soon, you know, realized, and I think the pandemic helped us with this, is to say this: when people fall, there is so much more involved. So I'm just going to share a new screen with you. Let's have a look. Here it is. And this is called a pen portrait. So hopefully that's come up for everyone. A pen portrait is generally something that can link lots of different things. So I'm going to make this a little bit bigger, and hopefully you can see. But, you know, an individual with a high falls risk and what we're doing to help prevent further falls. And we know there is so much involved, and things that we should always be considering. So, for example, you know, kind of right in our middle, we've got our falls risk factors, which we are going to go through. We know that everybody should be aware of falls risk factors, internal and external, to help make sure that we are understanding if somebody's a high falls risk or not. Part of those falls risks may be medication. We know how important medication is in regards to people's falls risk. And we've also got a really great medication resource to support knowledge on side effects to falls, which I will cover. If I come down here towards nutrition and hydration, UTIs, malnutrition and hydration, we know, again, having that knowledge about the importance of hydration, how we have to make sure that we are looking at how we're trying to promote as much hydration, the signs to spot a UTI, in order to prevent falls that, you know, very much are common when somebody does present with a UTI. If I come back up, we are looking at, you know, monitoring deterioration. We don't just accept that people are slowing down, that people do lose their mobility. We know that age-related changes happen, but we must be able to monitor deterioration and identify it quickly. An example of that is being able to identify frailty. You know, are people's needs progressing and are they needing more support? And we don't just want to accept that. We want to look at what we can do to support that person. Posture management when sitting, we know that if people are in the wrong positions, then it can make it more difficult for people to stand up, causing falls from chairs, difficulty breathing, chest infections, reducing overall function and health. We know that not everybody can position themselves. So we want to make sure that specifically if there's care staff we're working with, that staff must be able to position individuals with best practice. If you are volunteers working with people in their own homes, again, being able to notice if somebody's sitting in a crooked way, get support, get advice, and have a question and approach. Got neurological conditions as well, such as stroke, Parkinson's, dementia, which we're going to cover in a little bit more detail. Independence and mental well-being, absolutely huge and even more prevalent within the last 2 years. Things like low mood, reduced movement can affect the willingness to want to complete everyday activities, to go and make yourself a cup of tea. So what can we do to improve mental well-being and independence? Because that down the line is definitely going to affect somebody's falls risk. We've got injury, fractures and pain. Sedentary behaviour as well. When people are just not moving enough, we need to get people up on their feet as much as we can, if appropriate. We're going to talk about sedentary behaviour later on. And equipment. Are we having a question approach to ask if people are using their equipment correctly? Are they sitting in their wheelchair in the right way? do they still need their equipment? They might have, might be using their frame for 15, 20 years because one time they came home with from hospital with it. But do they still need it? Can we get people to do strength and balance exercises to help improve the individual while using equipment, but we also want to promote independence? So something that we put together to link all of these things together to say, this is how important prevention is, because all of these things can lead to people falling more, people becoming a new level of frailty, needing more support, and therefore that's affecting their quality of life. So I'm going to come back to my presentation next. And hopefully that does it. There we go. So internal and external risk factors. Some of this won't be new information for you all, but as a recap, it's a really nice way to be able to categorize what we're looking for. So internal risk factors, very much to do with that person, previous history of falls. And it's really important to note that if anybody has a history of falls, they are a high falls risk. And we're going to cover that within our falls risk assessment. Impaired balance and gait as well, sedentary behaviour and weakness, medication, history of Parkinson's, stroke or arthritis, fear of falling, and that's a huge one. I'm sure many of you have worked with individuals that they've had a bad fall and therefore they're very scared to do anything, linking back to independence. We've spoken about hydration, UTIs, incontinence, vestibular impairment to do with balance and inner ear, cognitive, such as dementia, Parkinson's again, and stroke, visual impairment, pain, dizziness and postural hypotension, foot problems and pressure sores. So there's lots here and lots more as well, and that's your internal risk factors. Moving to the external risk factors are very much to do with the environment, so things we can see around us. I know for those of you that work within people's homes who are supporting your clients or you're a volunteer, this is a very big barrier for you because you're having to work with people's possessions and families as well. But we know that we must make sure we're doing our risk assessments around to look at clutter and trip hazards, floor coverings and rugs, lighting, lack of appropriate adaptations, furniture. Is actually somebody able to get up from their very low, deep chair? Inappropriate walking aids. I touched on before with equipment. Is it the right height? Has it been checked? Are they sitting in the right wheelchair for them? Lots of things to consider there. Pets, uneven flooring, weather, clothing and footwear. So external risk factors very much to do with the environment. Just to mention, please feel free to add in the chat box if any questions. Please let me know. I'm going to go through some throughout. And then, so there are identification. That's our first step. We need to understand those internal and external risk factors. Now, everything that we follow is in our Hertfordshire pathways to assessing somebody's falls risk. Now, this is the same for in the community and in care providers as well. And the first thing we're going to go through is the FRAT. I'm sure many of you have heard the FRAT, and if you've heard me speak about it before, you're probably thinking, oh, here she goes again. It's the falls risk assessment tool. It is a nationwide use tool. Anybody can use it. It is not a clinical tool. And it is 5 questions which will determine whether somebody is a higher falls risk. And you can see that first question. Have you had a fall in the last 12 months? Straight away, if that is a yes, somebody is at a high risk of falls. So we need to discuss next steps with GP or, depending where you work, but we must take this seriously, that that person is now a higher falls risk. If somebody's on 4 or more medications a day, this is also known as polypharmacy, meaning multiple medications. And we know with multiple medications, the body can react, and it can cause a whole load of side effects. Sometimes people are on medication for years and years and years and nobody's reviewed it. Parkinson's disease, or if they've had a stroke, if they feel unsteady or have problems with balance, and if they struggle to get up from a chair of knee height without the use of arms. So if somebody's answered yes to 2 or more, we're looking at a higher falls risk and we must look at next steps. Now the FRAT is on our app, and if you haven't got our app, all you need to type into your Play Store or your App Store is HCPA Stop Falls. It's free to download, and it is brilliant for you guys. It's brilliant for families, relatives, friends, and your clients or whoever you work with, to be able to access information for falls prevention. So that's the FRAT. And it is ideally, we want to marry the FRAT up with a multifactorial assessment as well, to look at more factors in detail, to be able to develop potentially a falls care plan for someone, and look at more of those risk factors. And I'm going to go through that with you shortly. And then we've got the timed up and go. This measures both falls and frailty. It measures the time to stand up from a chair, walk 3 meters, turn, walk back, and sit down. It determines falls risk and measures the progress of balance, sitting to standing, and walking. Now, it's obviously not appropriate for everyone. You do need to do your risk assessment as well, that you can support that person to do so. If somebody does this walk fewer than 10 seconds, that is a normal walking speed. If they are greater than 10 seconds, they are risk of frailty, which means, it's showing the direct correlation between walking speed and frailty. And frailty is not a word we should just be throwing around. I could do a whole other masterclass on it. But it means that we are looking at somebody's resilience and their vulnerability to cope with events, stressful events that happen, physically and mentally. Greater than 30 seconds, then we're now looking at a risk of falls as well as frailty. It's a really good progress tool too. So if you are working with somebody to improve their walking, their strength, then doing a timed up and go, it allows us to document the time. That's really important. We don't just know that somebody's slowing up, or maybe somebody's not moving quite well anymore. We're doing this to document it, and that's really, really important to show that we are being proactive in preventing falls and further deterioration. And those assessments, they're all on our app as well, so you can have a look at them. Really clear directions to do, so really useful for you to have a look in addition to today's session. So a multifactorial assessment and intervention. This is evidence from NICE, so the National Institute of Care and Excellence. This is an assessment with components that aim to identify somebody's risk of falling. Again, previous falls history, you would have got that from the FRAT. Assessment of gait, balance and mobility, the timed up and go can help you with that. Osteoporosis risk, functional ability, what can they do? Visual impairment, cognitive impairment, and also home hazards as well. Now, generally, there isn't a tool that we use in Hertfordshire. It is something we are looking at developing within our team to have a template for this. And then we're looking at actions and interventions, and we're looking at exercise, home hazard assessments, medication reviews, and referrals. And we're going to touch on some of those today as part of our interventions. Gonna have a quick look on the chat. The app is HCPA Stop Falls, free to download, but I'll make sure I put it in the chat before everybody goes. In regards to equipment, is it always going through an occupational therapist to do this? And we will need to refer if there isn't a concern with equipment, with the way that people are seated and moving, then generally then it will need to be a referral for that, definitely. Will you get a copy of the slides? I won't be sending out the slides, but I will do a resource email and a follow-up email for you, so you've got everything that I've spoken about with all the guidance as well to have a look at. So again, according to the NICE guidance, so again, evidence-based, and it's always important we look at that we are sounding credible, we are looking at the evidence, making sure that we've identified those internal and external risk factors. We are looking at cognitive impairment, continence problems, falls history, as we've said before, footwear. That's a big one, and probably something that you all come across very often. Health problems, medication, postural instability, mobility and visual impairment. We're also looking at making sure we've got our risk assessments in place. We are documenting. That is really important. Documentation, showing what we have observed and what we're going to do about it, and also when are we going to review. Again, our interventions, what are we going to do? Referral again, and also using assistive technology can be part of that, including mobility aids, rails, modifications around the house. And we're going to touch on a little bit about equipment later on. So we're going to touch base on risk, reason and reaction. So some of the risks involved that we've already mentioned, why and what we can do about it. So number one, and this is my favorite thing to talk about because it is the thing that is evidence-based. So there are a few things that I'm going to speak about this morning which are not specifically linked to falls, but again, if we think about prevention, then they're going to be really handy tools for you. Again, according to NICE, balance impairment and muscle weakness, and we know that occurs due to aging. However, strength and balance training is the single intervention to reduce falls. This was developed through a study that I reckon a lot of you will know, 2005, the FAME study, which they did it based on a group of women with a history of frequent falls, who generally had poor outcomes. They took part in a tailored exercise program and also exercises to do at home by themselves. And it said that it lessened the chance of future hospitalizations and actually death, and reduced their falls risk. We know that exercise, physical activity, bone health and falls in older people are directly affected by activity levels as well as all the other risk factors we've spoken about. Risk of falls and current activity status, because actually 90% of hip fractures result from the impact of a fall, and we're going to touch upon bone health later on. Generally, physically active individuals have a 20 to 40% lower risk of sustaining hip fractures than sedentary individuals. That is huge. And we think about that bigger picture again. You know, if somebody has an injury from a fall, what is that going to do to them physically, mentally, quality of life? So all of this, again, us being proactive towards falls prevention. During later years, the focus of exercise shifts from preserving bone mass to preventing falls, because most fractures, as we've said, do come from a fall. We must look at exercise programs designed to reduce falls, must be a priority. Generally, a thing that I talk about every day with care providers is how much exercise are you doing? And generally, it is not enough. A quick question to everyone, please feel free to put it in the chat. What is the guided minutes that we should all be doing? That's every single adult. How long should we exercise for in a week? Tanya, straight in, 150 minutes a week, good, or 30 minutes 5 days a week. I was gonna say 5 times a day, God no. 5 times a week, 30 minutes, 150, vigorous. Oh, you guys know your stuff, excellent. Yes, you are completely right. Well done, everyone. So again, evidence.gov.uk, the chief medical officer's guidance is 150 minutes of moderate physical activity. Now, generally, how many days you should be doing a week doesn't really matter as long as you're adding up towards those 150 minutes. But as most of you said, 30 minutes, 5 days a week is a really great amount, as long as it lasts 10 minutes or more. Now, the most updated part of this, which was updated in 2019, is that some physical activity is better than nothing. So even if an exercise session is not appropriate for somebody, light activity still brings health benefits. To get people moving brings health benefits, rather than just staying sedentary. But we know that more daily physical activity provides greater health and social benefits. Muscle strengthening exercises on at least 2 days per week, and chair aerobics is listed as a recommended activity. But those at risk of falls should do exercises 2 days per week to improve balance and coordination. Now, this guidance is exactly the same for those with disabilities. It just can be adjusted to suit them. And this is for all of us. This guidance is for all adults, and especially those who are at risk of falling should be doing strength and balance exercises. But it's good to know that you all know the recommended amount. And I really like this as well, because generally when you're speaking to people, excuse me, when you're speaking to people, we all know it's good for us, exercise, physical activity, for quality of life, mentally and physically. But actually understanding these percentages is something else, and especially hip fractures by up to 68% that, you know, hip fractures can be reduced by. I will send this to you to have a little look, and with the guidance as well from the Department of Health. But it is evidence, we know. And again, making sure this is part of, you know, people who we support their lives, even just physical activity, not necessarily just exercise, it is really important. So we have some resources for you. You probably know all about this already. I'll quickly just move forward. We have mobility exercises, we have stretches, we have standing balance that we have developed by our, you know, clinical lead to make sure it's suitable for anybody to do on a one-to-one basis. And they are very general, but it's how we embed that within our everyday work. If you're a volunteer, if you're helping people up in the morning, can we get some exercises going, and to make everybody aware, families, clients, whoever you're supporting, aware of that these are there for you. And if I had more time, I would go through every single one of these with you to get you moving, but I'm not going to this morning because we'll be here all day otherwise. But we have got these exercises with instructions and videos on our app, and also online too. So I'll make sure that I'll follow up with this in an email as a reminder. But we've got some nice mobility exercises, stretches, and also some standing balance as well, including a sit to stand, which I will go through with you shortly. And we've spoken a lot about sedentary behaviour and how important it is generally to get people up on their feet rather than staying seated. And we've spoken about bone health as well and its relation to falls, osteoporosis. But generally, for those who are 65 and over, 2 hours of sitting time do start to affect bone markers. And what they do is they measure our turnover of bone. So the process of bone tissue being broken down and then new tissue being built in its place. Have a guess in the chat for those who are under 65 and under 65, how long we have to sit for this change to take place. So it's 2 hours for those who are over 65. Let me know what you think for those who are under. We've got blood sugar rising, reduced muscle strength, bone density, risk of falls, blood flow and circulation, good and healthy cholesterol can drop by 20%. But generally, we know that older people are spending approximately 12 hours a day, 80% of their waking day sedentary. So some of you have said, Rachel 4, Jane 3, Nicola 3. It is 4 hours, Rachel. Well done, you got it right. It is 4 hours. You were all on the right lines though. 4 hours for us, for under 65s. This process happens. So everyone quickly have a move around, stand up, sit back down again, and make sure you move after this webinar. Do not carry on working. We must keep moving for everyone. So we know sedentary behaviour, increased risk of falls, osteoporosis, pressure ulcers, and we must promote physical activity and independence. So we've spoken about fractures. We know that they cost £1.1 billion out of the 2.3 of overall cost of falls. Sitting all day can affect our bone health because bones are living tissue. As we stand up, they become activated. Our weight is being loaded onto our skeleton and it activates our bones. We're using them. If people are in a sat position, they're not straightening their legs, their knees are bent, they could be in a crooked position, not breathing properly, opening out their chest. So when they do stand up, what's going to happen? We're looking at, balance and gait problems because of that lack of weight bearing. And we're looking at osteopenia and osteoporosis as well. If you don't know, osteopenia is the stage before osteoporosis. We aren't at critical levels of bone density, but we are going that way, whereas osteoporosis is critical levels of bone density decreases, and therefore if somebody falls, they are likely to break something such as a hip. So sit to stand, and I feel a bit silly doing this because I cannot see anyone, so don't let me do this by myself. But technique to stand up properly. So if everybody on their chairs shuffle, you're going to hip walk to the front third of their chair. Bring your feet out just by feet hip width apart, ankles slightly behind knees. Ideally arms on a chair, I don't have, but ideally hands on the arms of the chair. Nose over toes. Now, a lot of people say push up and stand up. And actually that disables somebody because you're not encouraging them to use their legs, to use their bodies in a functional way. This is a functional movement, a sitting to standing. So a really good cue to take away is thinking about pressing our heels into the ground, because what that does is it activates our glutes. Now our glutes are our bottom muscles, and it activates our bottom muscles, which are key for stability in the body, big global muscles. So if your balance isn't quite there and somebody tells you to push up, what are you going to do? You're going to press your arms down, put the stress through the shoulders, through the arms, and you're going to stand up. And you might see people reach for their walking aids and try and pull themselves up. But let's again break the movement down, nose over toes. If you say ready, steady, stand, or 3, 2, 1, press your heels into the ground and then stand up. We start to activate our leg muscles a lot more. We're not disabling somebody by just using the upper body. Now, if somebody can't get there, that's okay. Start with the shuffling backwards and forwards. You can concentrate with a lift of the bottom by just pressing the heels into the ground and just lifting that bottom up. Sometimes people need momentum, a little rock backwards and forwards with the correct hand positioning. But sitting to standing is something that people don't spend time doing with those that they support, because it can take time, but it's a huge part of independence. And it is something we should all be doing in the correct way. Medication and falls. We know that multiple medication, also known as polypharmacy, is a huge part of falls. And I've included it in today because it is a big part, it's evidenced. However, generally people don't think they need to know about fall side effects if they are not giving medication to anyone. And that's completely wrong. We should all be aware of our falls risk, of a falls risk and medication, so we can question actually whether we need a review or whether something's not quite right. And I will send a PDF out to you after, or Will or Chris will send it out. We've got a medication resource on the app and as a PDF that in A to Z has common medications and their side effects to falls. And if you've got a team, or you're a volunteer, or you're working within you're a provider, a care provider, everybody should have this knowledge to be proactive and to say, actually, something's not quite right. Before this person falls or before anything happens, let's go and look at medication. And actually some evidence that I looked at yesterday was in regards to those who are on blood thinning medication and what happens if they fall and hit their head. And it is important that we are calling emergency services for that, because we just don't know if they have internal bleeding, and we must know that how that medication can affect somebody who has fallen. And I will give you that evidence as well. There's from CQC and NICE guidance, and I will send that over to you to have a look too, to make sure you can pass down to your teams, to your colleagues, to make sure that everybody is aware that if they are falling, they are on anticoagulants, that we are looking at sourcing medical help, because we don't know if they are internally bleeding. So within information like that should be within management plans, should be within care plans, that everybody knows, looking at medication reviews and having that awareness. And some common side effects, as I'm sure you all know, quick time check. We know how they can contribute to falls, and it is important that we have that awareness. So equipment and aids. Equipment, we know that mobility equipment is very necessary a lot of the time. However, it can, if it's not tailored to that person, or it's the wrong aid, then it can cause falls as well. So having the correct walking aid is key, and it must be assessed by an allied health professional. We must document that we are checking walking aids as well. Are we checking for wear and tear? Are we checking that they've got their right mobility aids for any faults, for any damage, and audit it, document it? It's part of prevention. Sometimes people hate using their equipment, and you can't blame them for that. So there are things that I'm going to go through next that can actually aid that, to help somebody create a little bit of ownership towards their equipment. But, you know, we can get professional advice as well from Hertfordshire Equipment Service or Herts Ability, to if regarding any vehicles, but we must question it, and that's important. We should all have a question and approach to think, actually, have we done enough here? Do we need to get advice? So we've got Light Your Night, not just for equipment, but for around the home. This was trialled in Colchester, and it actually reduced their falls by 75%, because when they were doing their auditing, they noticed that 50% of them were at night time. So actually we should be thinking, right, what do we need to do then? What is it? Is it in the toilet? Is it getting out of bed? You know, where are these falls happening? So things they included were footprints, decorating frames as well, which I'm going to go through next, illuminated light switches, movement activated lights, and that's important because not everybody wants a lamp on. So looking at where we can get movement activated lights from, you know, Amazon, they stick up on the wall, or sensor lights to, you know, to help people's way to the bathroom. Again, part of prevention, looking outside the box a little bit more. Fix up your frame, my favorite one, because it's a really lovely thing to do, to help create ownership over people's equipment. Frames, they're boring, silver, they can blend in with a wall, people can get mixed up with them. So looking at making sure that we can decorate a frame, but it's person-centered to that person. So it's not just about putting some tape over it. Actually, is it their favorite color? Is it something that they want to do? You can see in the picture, and this is what we actually did a few years back. And this lady here, you can see that she loves red. Red was her favorite color. She always dressed head to toe in red. So there's a lovely preschool child there. She was decorating her frame in red tape, to help, again, be able to identify that it's theirs. Now, we do have to be careful that we don't cause a falls risk. So we're looking at, obviously, infection control as part of it, and also that we're not affecting the way that somebody's holding their frame or where their feet are, or that it's off balance. So we do need to think about actually that it's suitable, not go crazy, because it is quite easy to. Glow in the dark is a brilliant idea. This was from a Bupa home that sent us a picture of their glow in the dark frames, and some other lovely pictures there. Jean has gone all out with her feathers. So looking at that it's specific to that individual. Now, neurological conditions, stroke, Parkinson's, sometimes we cannot stop some people from falling, as we've said, but we do want to make sure that we're covering all bases. We're making sure people are independent. We know that, you know, weakness, one-sided weakness is very common with people who have had a stroke. We want to make sure we're looking at posture, we're looking at positioning as well. If we're doing exercise with them, we want to look at strengthening that side that might be weaker than the other side, not just to focus on their good side as such. Of course, referrals as well to the right people, because, you know, they are at risk of falls due to loss of balance. So again, specific interventions, risk management plan, supporting individuals with correct exercise, and if appropriate, making a referral. If you've noticed that they're not sitting properly, they're worsening of posture in their chair or wheelchair, we need to make sure that we get support. So you possibly refer to wheelchair services, physiotherapists, speech and language therapists, OTs. It is really important. And Parkinson's as well. We know that tremors, freezing as well, shuffling gait can affect somebody's falls risk. We know that neurotransmitters don't operate as usual. So that means that movement, balance, coordination is affected. And also medication's a really important part, that it's given at the right time. That we're making sure that, again, in relation to falls risk, equipment, posture, positioning, again, sometimes individuals may place themselves on the floor because they feel safe and they have that security. And that's a result of dopamine in medication and causing those neurotransmitters to fire. So there is a lot of unwanted movement and things that we see that can cause that person to fall, as I said at the beginning, balance and that shuffling gait, risk of falling forwards. And a few things to finish up with is things we should be including when we are looking at that person we're supporting in relation to prevention, quality of life, to enable someone. And part of that is goal setting. And actually, Public Health England suggests that everybody needs to raise awareness, motivate and signpost people to help improve health and well-being. And again, thinking back to prevention, we aren't just thinking about, we've identified risk factors and that's it. We're looking at that bigger picture. So are we setting goals for people to achieve things, whether that's to stand up and go to the toilet by themselves, or to be able to walk around the park, and all of this contributing to movement, to quality of life, to potentially strength. And we need to make sure that it follows this guidance of SMART, which isn't new. I'm sure you've heard about. The goal needs to be specific to the individual. We need to be able to evaluate it and measure the goal. If it's possible for that individual to achieve it, and is it important to them? My goal is completely different from your goal. My goal for the last however long, many months, is to be able to do a full press up, and I can't really get past 2. I'm sure that's not all your goals. And time bound. Can it be completed in a suitable time frame, and are we reviewing it? That's really important to think about. Again, quality of life for those that you support. And a really nice strategy to take away is the NHS 5 Whys, and you may have heard of it, to help encourage positive conversations and a question and approach with your teams, with the families, relatives, whoever it is. That let's ask the question why. We don't just leave things. We write down a specific problem. And then we use this brainstorming technique to keep asking why. And it's very straightforward. We've got a problem. We ask why. We ask why again. We ask why again until we start to come up with a solution or something that maybe we haven't tried. So this, for example, if you think about the home that used Light Your Night, they were looking at their nighttime falls and they asked why. Well, actually, that might be something to do with lighting. Why? Because people are getting up and they can't see where they're going, and they keep asking why until we come up with something that maybe we can try that we haven't done before. And it's a good way to encourage people to be proactive and come up with solutions together and have a change of thinking, again, a question and approach. And I'm right on time, is the last thing I wanted to go through is positive risk taking. And as I said at the beginning, we know that falls are going to happen, but this does not mean we keep people sat down. We want to take positive risks because of the outcome. And again, documentation is really important. So this documentation, you can see on the screen, is from the Royal College of Occupational Therapists, and they said that we should be documenting our positive risks by understanding the value, understanding the risks associated, and then doing like a RAG rating for likelihood and severity of that fall happening. And actually, how are we going to manage it? What are we going to do? Because we still want to make sure we're encouraging people to do as much as possible. So yes, this is a falls masterclass. We've gone through internal factors, we've gone through assessment and some specific interventions and the evidence, but also it's so much more than that. It is very much to do with making sure that we're doing all we can to keep people well, keep people moving, because that evidence always comes back towards physical activity, levels of frailty, and also people's falls risk. So where I'm at the moment and where we see the gaps is that developing a falls grading system, we know that falls happen, that it's not so straightforward. So understanding a grade for a fall is really important, and it's something we've been working with. We've been working to looking at the evidence, what is around, to make sure we're understanding the severity of that fall, because they're not all the same. We want to develop a template of a multifactorial risk assessment to go alongside the FRAT, which gives you your high or low risk, your number that you work out, but that multifactorial, because NICE tell us what's meant to be in it, but we would like to develop some templates. And also we're updating some current pathways in regards to falls prevention within care homes as a sub-project at the moment. There's always so much more work to be done, but if we all understand each other's resources, understand each other's roles, and connect, which this is so great to do, then we're looking at making sure that we are proactive and we are empowering individuals to have that question and approach, and to look at falls prevention seriously. So I'm going to stop sharing my screen. And if we've got any questions, Will.
Yes, absolutely. First of all, fantastic. Thank you very much, Verity. That was incredible. And bang on 12 o'clock as well. That's impeccable timing. So if people who are with us still can wait, we've got a few questions which we'll go through now. I'll start with those that are in the Q&A box. So we've got one specifically on the FRAT tool, from Eleanor, which is: every single patient we assess will score 2 or more because they are a yes to questions 2 and 3. We complete it as part of an initial assessment, but sometimes they've already reported independent mobility and independent with ADLs, but the score triggers a further, more in-depth assessment. Is there any way around this, because it doesn't necessarily take into account someone's acute stroke recovery?
So I'm just reading that again, sorry. Every single week's got 2 or more, yeah. So it still makes them a falls risk assessment. However, it's also down to those interventions, the multifactorial assessment as well, to look at that functional, those functional activities, activities of daily living. So there are activities of daily living tools as well to make sure that we are looking at what people can do. So it is important that we are documenting that falls risk, but also if somebody is through recovery, let's document that as well. It's because they are a falls risk, we do need to do that more in-depth assessment. But you're right, it doesn't take into account somebody's acute stroke recovery, because I guess it can't take into account every single person's recovery. So looking at functional skills, activities of daily living, and those kind of tools. I don't know if you've got any of those tools to help build that picture, and that's why very much so we're looking at those falls assessment plans, which of course are different for every single person. Happy to talk about that with you more. It's quite a broad subject, so I'm happy if that doesn't help you, Eleanor, for you to send me an email and we can talk about it.
Brilliant, thank you, Verity. Another one from the Q&A. So regarding strength and balance training, so if as a professional, excuse me, you're not trained in strength and balance, would this then be a referral to a physiotherapist?
Yeah, so the strength and balance, generally to teach a class, you cannot unless you are strength and balance trained. However, the exercises that we have, they're very much doing a one-to-one, so you can work with people. They're very general. I can't give you advice on individuals on it. But yeah, you would have to refer. But also, we are running more information on strength and balance classes in Hearts.
Yeah, absolutely. I mean, I'll finish with that. Just going to jump to a couple of questions that are in the chat as well, to make sure we don't lose them, which also may lead on to what we discussed. So Sherlyn has asked, is there a list of Falls clinics available and what the referral process is?
I actually don't know. I know that they've all been closed due to COVID, but leave that with me. I can see what I can do, but I don't know on the top of my head.
Brilliant. And I think the last question that I've seen, which was from earlier in the chat, was asked, well, I'm not sure if this was to you or to us as a collective, but do you take referrals for those at risk of falls? I don't know if you want me to answer that.
You go first, Will. I'll come in after specifically on what we do.
Okay, so I mean, very briefly for Heart Sports Partnership, we fund a series of classes of strength and balance classes across the county, which are delivered by the Stevenage FC Foundation across different levels of frailty. So from how they term it as beginners through to sort of intermediate and people that have got much better balance. So I'll circulate details of those classes to everyone that's attended. And also, because I know there's a lot of people in this chat that might be in similar positions, that they have great offers. So if you do send those through to me by the end of today, I'm happy to include that in the email that goes out to everyone, because everyone's obviously here because they've got an interest in falls prevention for whichever way reason. So please do send those over. Verity? Yeah,
I think it's so important for us to know what is going on, because quite often it does get miscommunicated on what's available, and it's brilliant that we've got those classes. Referrals from us, I don't know exactly where everybody's from, so our funding is generally for care providers who are members of HCPA. So it will we do have, I know that Hills, you've been on, I don't know if anybody's been on from like Age UK, also there's a few other volunteer organisations that we've done training for that are members. So you may not be, but generally we're only because we're a providers association, that's generally where our funding is. However, our resources are for everybody, so please use as much as you can, and I make sure that I'll send all of them over to you with all the evidence and good places to keep on top of your reading.
Fantastic. And equally relevant as well, at HSP, we're working on an activity finder tool at the moment, which is designed to help everyone from all different backgrounds find suitable physical activities. And we're going to be encouraging all the falls prevention classes to be loaded up on there. It's an online tool so that you can find the most suitable class in your kind of geographically most suitable area as well. So I'll include details of that when we send them out. We've had a couple of last minute questions come in on the Q&A. So someone has asked, do the positive risk assessments get reviewed?
Yeah, positive risk. Yeah, positive risk should always get reviewed, and because if people change, they should all, if we're documenting positive risks, we need to always document, review and monitor, because people change, and of course those risks can change as well, so always, and that's kind of across the board. So the FRAT, timed up and go, generally always reviewed if there's any change with anybody, or some people do them every month, and that's what we advise.
Fantastic. And the last question I think that we've got is that many people are mobile when they go into hospital, then they're discharged from hospital and they are immobile. How can hospitals support older people to remain mobile whilst receiving their treatment?
Yeah, it's a big gap, isn't it? And it's something that we started to develop our frailty information on, because people come out of hospital and they're not quite the same, and mobility is a big part of that. There is some work being done by NHS and Public Health, which is running from November to February. And it's called the Deconditioning Games. I don't know if anybody's heard of it. And it's something they're trying to work with within hospitals, as well as people coming out of hospital, working on their discharge, and to keep people moving. And you have to sign up. I will send information on it as well. And you have to sign up, and it's like it's a leaderboard system, and you get medals and things like that. And they've got a torch that they've made, and they're taking it around Hertfordshire as part of the games to make sure we're doing all we can to improve people. So I know that they've been to Watford and Leicester Hospital this week, trying to encourage this for people leaving hospital and also discharged to assess beds. But it is a gap, and it comes into enabling people, not just that they have a re-ablement team, that if they are having care, support, that everybody has this approach to keep people moving and independence and look to getting people out of bed. But it's a huge subject. I don't know how to answer it simply.
No, that's brilliant. Thank you very much, Verity. So I think, apologies if we have missed any questions in the chat. I don't think we have, but if we have, please feel free to send them as an email afterwards, and we'll make sure they get answered directly to you. And so all that really leads me to is a huge thank you to everyone that's attended. We've had some really good numbers throughout the event, and they've been consistent as well, which has been fantastic. But equally, and well, not equally, a lot more so, a huge thank you to Verity for joining us today. Incredibly informative presentation. I know it's given me loads of things to think about, and there's been some really great comments in the chat throughout of lots of people finding out they've been standing up wrong their whole lives, and lots of
tell you what, touch your bum when you do it, and that's how I teach it, because you activate through there. So generally people just tell everyone to push up, and we shouldn't, and it's a big part of independence, and it's a strength exercise, which I guess I didn't mention, but it's a strength exercise, so huge. It's evidence-based, so definitely needed.
Fantastic. And lots of thanks coming in on the chat to you now. So yeah, we will follow up to everyone that's attended with everything that Verity's spoken about in terms of materials and bits and pieces that we can circulate. And just to reiterate, if anyone who's attending now wants anything circulated to everyone else, as has been mentioned in the chat, there's all sorts of classes and support services that people are running across the county outside of what we're directly doing. So our role is to try and increase awareness of everything that's going on to increase the health of the population as a whole. So please get them in. I'll try and get that circulated Monday, if not Tuesday of next week. And apart from that, please feel free to get in touch with either myself or Verity if you have any questions. And if not, we look forward to seeing you again soon. Thanks very much, everyone.
Thanks, everyone.